Hi, case of the day, another week, and today is Monday, and we're looking at the 106th case, the Milky aspirate clinching the diagnosis. So, this is a 55-year-old with non-specific abdominal complaints, had a CT scan done. I'm not sure whether an ultrasound was done earlier, but the patient had this multiloculated cystic lesion, quite a few prominent vessels at the periphery, but otherwise just septate, no solid components, and he was referred for a CT guided biopsy. But when you look at something like this, these are your differentials that would run through your head. But there was no stranding, there was nothing in the kidney, so it pretty much looked like one of these neoplastic cystic lesions. He came today for a biopsy, and that's 9 days later. And the lesion had changed in shape a bit, even when you looked at the sagittal and coronal images, telling us that it's deformable. And deformable means it's basically fluid containing. Fat containing lesions can also be deformable, but it therefore confirmed the fact that this is just likely a benign cystic lesion. Initial thought was to do the biopsy in the supine position, but then I realized that prone would be better. And I gave contrast to make sure that we could identify the vessels clearly. And there was a straight path into the lesion, bypassing the vessels next to the kidney, and I did that using an 18 gauge barred gun, and I used a blunt tip to navigate this. So I used a sharp tip up to here and then the blunt tip up to here. And then once I was inside, the milky white fluid was just flowing freely out, and I eventually aspirated about 35 cc of it. The lesion's already reduced in size, so by the time I introduced the gun, it had shrunk by more than 50%, and there was absolutely no solid component. I tried about 3 times, and there was no core tissue. So just the aspirate was to be enough to make a diagnosis, and the lesion has reduced in size by almost 90% at the end of the procedure. The triglyceride levels came in the evening, and they're 2720 milligrams per deciliter, so extremely, extremely high. Therefore, confirming that the fluid is lymph, and the diagnosis, therefore, is of a macrocystic lymphatic malformation. I was looking at the literature, and this article from the Japanese Journal of Radiology is very comprehensive. It also has a huge list of differentials categorized in multiple ways, and if you have access to the article, then this is it's a wonderful read. And these are all lymphatic malformations. Earlier, there were multiple terms used, and now divided into macrocystic, microcystic, and mixed, and this is what they would look like. So our patient clearly has a macrocystic lymphatic malformation. I have two other similar cases in the past, but both of those were mesenteric, which I think is a commoner location for these lesions. And if you want, you can go through that. This was in ctbiopsy.com, because again, the diagnosis was established on the basis of the lymph that was picked up, and the triglyceride levels were high. But here I had histopath material that confirmed that this was a lymphatic cyst. And about 5 years ago, there was this patient who had a central calcification. And the question also was, could this be a cystic teratoma or a dermoid? But the aspirate was clearly chyle, and then the histopath confirmed the diagnosis. Most of the literature, funnily, doesn't talk about image guided aspiration and biopsy, but they say that when you suspect a lymphatic cyst, to straight away go in for surgery and then confirm the diagnosis. But I thought this is quite straightforward and simple. Put a needle inside, get chyle, confirm it with triglyceride levels, and you have your diagnosis. I mean, that's a lymphatic cyst, and because there is a cyst into which you're putting a needle, then it automatically becomes a macrocystic lesion. That's the seminar, now just 2 weeks away. My WhatsApp channel, and thank you so much for viewing this.